All right, we're going to go over the elderly population and palliative care. So that is chapters 47 and 52 in the 5th edition of Darby and Walsh. And here are the objectives. It's a little bit of a lengthy list, so go ahead and read those on your own. So we'll talk a little bit about the demographics of the aging population. Aging adults, they experience higher rates, they're higher risk, and there's higher rates of chronic disease among the elderly. And in 2012, the number was 60% of older adults managed at least 2 chronic conditions. So they could have more, but at least 2 chronic conditions. So heart disease, cancer, bronchitis, emphysema, which would be COPD, stroke, diabetes, Alzheimer's disease, arthritis, vision and hearing problems, and this is probably not an exhaustive list. So a couple terms for you to know. The difference between geriatrics and gerontology. Geriatrics is actually the branch of medicine that actually treats the illnesses of older adults, where gerontology is the scientific study of factors that affect normal aging and the effects of aging on individuals. So ology is studying, and then the geriatrics is actually concerned with like the treatment. So they're not interchangeable, they're different terms. So thinking about a few things here, we want to think about our older population in terms of chronological age versus functional age, because when we have individuals who have chronic conditions, depending on how those chronic conditions are, if they're stable or unstable, we may have a young old person or an old young person, if that makes sense. You can have somebody who's 60 years old but is very sick and has a lot of debilitating disease that is affecting many areas of their lives. Or you could have a 95-year-old person that's running marathons. So chronological age is their birth, measured like from the time of their birth. Functional age is based on their ability to perform different activities, their performance capabilities. And then we have activities of daily living, and those are broken up into activities of daily living and then instrumental activities of daily living. So activities of daily living would be bathing, dressing, toileting, being able to transfer themselves from a bed to a chair, where instrumental activities of daily living would be, oh shoot, I'm not plugged in. Sorry about that. I'm sure the audio is probably a little better now. Where instrumental activities of daily living would be managing money, preparing meals. So there's a difference in those terms. I'm going to pause here for just a second because my dog is whining. Hold on. Okay, and then we also have acute conditions, which would be something like more intense. Somebody would get sick more intensely, and they might die from it. Back in the early 1900s, where today we manage our conditions, they become chronic conditions. So they're managed through medications, and patients kind of, in a sense, they stay sick longer, but maybe their quality of life is still okay, and they live longer because of it. So we call them chronic conditions. So oral changes in the aged population, we see dental changes, we see periodontal changes, we see oral mucosa changes, changes in the tongue, the amount of saliva, things that are introduced because of drug oral manifestations from drugs, and then other changes as well. So in general, the aging population has declined in the amount of edentulous patients, meaning total tooth loss. So between the years age 65 to 74 years old, there was about half the population in the 60s had all their teeth lost through some whatever it was, disease process of either caries or perio or something. But then we look 20, 40 years later, it's cut in half. So at this point, I definitely should have updated that just because now we're at 20 years from 2002. So I'm not sure if it's decreased. I thought the last thing I saw was something in the teens, that only a certain, like a smaller percentage, like maybe 15 to 18% of those over the age of 65 were completely edentulous. Nevertheless, the amount of people with restorations has increased dramatically. So those with full dentures is not nearly as prevalent as it was 40, 50 years ago, but those older individuals now have a very high rate of more complex restorative prosthesis in their mouth, which kind of has a whole other set of problems for cleaning around. So changes in enamel, cementum, dentin, the pulp, we see things like fractured enamel, we see the increased staining as someone grows older, the slower production of dentin, and the overall shrinkage of the pulp. So the pulp changer becomes smaller. We see attrition and abrasion, so just a wearing out sort of the teeth in general. So if it's due to pathology, if it's due to a disease process, the most prevalent thing we see as far as caries is root caries. And that is because we see a higher rate of recession, less saliva, or the quality of saliva or the composition of saliva is impaired or changed. There's an inability to sometimes thoroughly remove all the plaque and food due to dexterity issues. Previously restored coronal and root decay is common, so we might see recurrent secondary decay or root decay. There may be an overconsumption of soft kind of plaque retentive or food retentive foods because of diets, maybe in like nursing homes. They may eat a softer diet. It may be more higher rates of fermentable carbohydrates. There may be frequent snacking, maybe smaller meals spaced out, so there's more of a chance for those acid attacks. Age-related periodontal changes. Now, in the absence of disease, so we're talking about a healthy 75-year-old or a healthy even 80-year-old, there's really insignificant changes if you're talking about someone who their entire life has had a relatively healthy mouth. They've never really had a bout with major perio or anything like that. If that person doesn't have a lot of chronic conditions, in the absence of disease, we don't see, it's not like you get old and you lose all your gum and bone. It really is dependent on the amount of disease exposure. So that's a really interesting thing to note. The quality of bone can be reduced related to metabolism and reduced healing capacities and the reduction of gingival nerve and blood vessels. So there is some maybe very moderate changes, but these are all really exacerbated and seen in much higher number in the presence of disease. But if we're talking about a healthy older individual, you're not going to see massive periodontal changes, which I just think is really interesting. Pathology related, so if they're in the presence of disease, it's an association but not a cause between the increased age and increased recession, loss of attachment, prevalence of inflammation. So if someone has had periodontal disease in the middle parts of their life, then they have a higher predictor of having that as they age, because then you're going to start to have all those extra things that you have to think about: dexterity, lifestyle, cognitive ability, all of these things that are going to kind of layer on and make it more difficult for them to maintain a healthy periodontium when they're older, especially if they have dealt with it in their middle years. Oral changes in the mucosa, age-related, again, if in the absence of disease, really there are not a massive amount of changes. It's really minimal changes occur. If there are pathology or something else like medications or something, medications or a systemic condition, then we're likely to see far more changes. Lips can appear dry, drawn down, loss of elasticity, dehydration will make that worse. Angular cheilitis, ill-fitting dentures, the rate of that oral candidiasis, of course, with those two things. Oral cancers, average age of diagnosis is 60 years and older. We are seeing more oral cancer younger because of the HPV connection, but it used to be classically oral cancer was something that you predominantly saw in like older men, was like the major category, but that has changed over the years. And then tongue changes, so decrease in the number and sensitivity of the papilla and a decrease in the sense of smell. So we do have some changes there. Foods less appealing unless it has a stronger flavor. So things, we do tend to see things with more salt and more sugar to add flavor. And of course, the salt isn't good for, you know, a number of things going on in the body. And then sugar is not good either because we worry about decay, but then also sugar is inflammatory to our whole body. It causes inflammation. So number of reasons, you know, you don't want increased sugar, but nonetheless, it oftentimes, you'll see that more in, especially like in nursing homes, they'll have pudding and, you know, things like that for the residents to eat. Nutritional needs may not be met. There could be some vitamin deficiencies that can also affect this area as well. So sublingual varicosities, those are those big kind of swollen looking vessels, dilated vessels under the tongue. So you get the deep red or bluish black dilated vessels, either on either side of the midline, on the ventral surface or under the undersurface of the tongue. Nutritional deficiencies, anemia, so there could be an atrophic glossitis or a burning sensation if they're anemic. We also can see a smooth, shiny, denuded tongue as well that can be attributed to nutritional deficiencies. And then if the patient is edentulous, that their tongue does tend to kind of spread out a little bit and fill in the size of the oral cavity, so you see an increased size in the tongue. Salivary glands, again, interestingly enough, it's not necessarily that they're going to get just their salivary glands are going to shrivel up and die just because they're aging. Very often this is just specifically related to medications and systemic diseases. So also things like radiation therapy, tumors, and of course medication, like I said. If present with no medications, then we want to evaluate an underlying disease or salivary tumor. There's things like Sjogren's syndrome, that autoimmune condition. It's most frequently observed in postmenopausal women, 60% of them being typically over the age of 50. Oral mucosa is extremely dry. The saliva is ropey. First, they'll see the atrophy of the papilla, and later kind of a smooth and lobulated tongue or bumpy tongue. So those are the changes that happen over the tongue, on the tongue, when it's like kind of in a chronically dry environment. So that is definitely something that you want to address and help patients with for comfort as well. Salivary changes. So what are, you know, you obviously this is review for you, but purposes of saliva. It's a lubricant. It assists in the breaking down and the swallowing of our food. It helps us with our speech, you know, a dry mouth, everything, your tongue gets stuck to the roof of your mouth, it's harder to talk. Facilitates retention of oral appliances, so it helps kind of with that suction, and then provides a source of minerals for remineralization of the enamel, so it's directly beneficial to teeth, neutralizes the pH of our saliva. And so if there's diminished saliva, then we're going to have all these negative effects like altered taste. Things aren't going to taste the same or taste as good. We're going to have a lot more plaque retention. Obviously, that's going to lead to more caries. We're going to see more inflammation in the mucosa. Mucositis appears dry and inflamed. With someone who's edentulous, there's going to be effects on the retention of the denture, the comfort, and their ability to chew and speak with the denture in their mouth. It just makes the whole thing a lot more uncomfortable and difficult. So if there's a drug-induced reduction of saliva, then we're going to see some other negative changes. A third of prescriptions are for older adults, and on average, an older adult will take more than 3. But if they're institutionalized in a nursing home, in an assisted living home, on average they take 5 to 7. But I have seen much higher numbers in some reportings, but that's kind of, I guess, more of an average. 5 to 7 prescription medications. Most commonly, these would be things for like heart medicines are a big one, but analgesics, pain, control their pain, diuretics, diabetic medications, oral hypoglycemics, antihypertensive medications, antidepressants, we know that's, and sedatives, we know those are going to cause a lot of xerostomia. So when we have drug-induced changes, we're going to see possibly some gingival enlargement. We're going to see a lot of xerostomia. For gingival enlargement, things like those anticonvulsant medications, those calcium channel blockers, and immune suppressants, those are all going to be drugs that could potentially affect the gingiva. In that way, xerostomia, again, it's the antihypertensive, antipsychotics, antidepressants, muscle relaxants, antihistamines, laxatives, and diuretics. They can probably just to name a few of the major ones to cause xerostomia. So other things that can be noticed as well can be like the halitosis or malodor, bad odor, bad breath. And this can be GI, but this can also be upper respiratory, so excessive mucus or infection. It could be because they're pouching food in the vestibule. Their food is just sitting in their mouth, kind of getting stinky. Food between the cheeks and the lips of the soft tissue, an inability to swallow it well. They just kind of pouch it because they can't get it down. Or they lose the sensation in their mouth that there's stuff there. Like if we have something stuck in our vestibule, we feel it and it kind of drives us crazy, and we like try and get it out with our tongue. But they lose that sensation, and they also lose the strength of their muscles of mastication and their facial muscles to kind of help work that food out and down their throat. They lose all of especially if they are, let's say they're on sedative, certain drugs that increase that sort of sedated state of mind, that might exacerbate it even more, you can imagine. So this is much more common in older adults who might be institutionalized. But you might see it in your patients as well who are still living at home, so it's something to be aware of. So what do we do through the assessments? So the different process of care and assessments. So we want to observe our patients. We want to think about their personal situation, their personal barriers, their personal struggles, what is going on in their life that is going to affect their oral health, their ability to maintain a healthy oral cavity. We want to think about it in terms of what kind of systemic conditions they have, what kind of medications they're taking, and their past dental history. What are they at high risk for? So we want to kind of think about all of those things. It's a lot to think about at the same time, but you get better and better at it as you do. And then extraoral and intraoral, of course, we want to encourage frequent self-evaluations for intra and extra oral exam to check for oral cancers and swelling and infection and bleeding and that sort of thing. We try and take our regular x-rays based on their risk assessment. Oral hygiene status, we want to observe their ability to perform good oral hygiene and their dexterity, their vision, their cognitive abilities. Nutritional status, we want to think about their ability to get healthy food, nutritious food, what are their habits, their ability to digest and chew, and then what kind of a diet is being prescribed to them if they're in an institution, or if they live on their own, if they can talk a little bit about their diet as well. Modifications, we want to think about the accessibility of them to actually get to the office. So just practical things like, can they get into the building? Can they get down the hallway? Things like that. Also, we want to be aware of their exhaustion level or how easily they would get fatigued, stressing. Like I said the other day in class, keep those appointments short and happy if you can, limiting them to 2 hours, and thinking about their transportation time, how long it takes them to get to the office and get home, because that's gonna wear them out potentially as well. Assistance with walking, dental chair position, level of knees or higher. If patient cannot bend, they have back problems and neck problems, they're going to ask for support in the neck, support behind the knees, things like that, maybe not laying back as far. The arm of the chair should be in a place that they can get into the chair, and then kind of give them some support, somewhere to put their arms. And then, of course, we have to think about the potential for wheelchair transfer. We never want to transfer anybody on our own. Even if it's a one-person transfer, somebody else should always be in the room to support you in case you fall or you drop the patient. But I would never recommend that you transfer someone on your own. That's just my personal recommendation. Modification reviewing forms. We want to think about their ability to hear and see, and if they can understand and read things, or if we need to help them with those. So assistance with forms, if they're visually impaired, larger prints. Interviewing, we want to think about our mask wearing and how that can be a sound barrier. Low pitch voice and removing your mask if possible, which nowadays it's probably not possible. So we just have to do our best to work around this issue. Shouting is typically unnecessary and ineffective. Just a stronger lower pitch without feeling like you have to shout. And then eliminating background noise, thinking about the music that's in the room, thinking about other conversations that are happening, think about the sound of the drill and the suction in the other room. Is it impairing your patient's ability to hear and understand? And then hearing aids, leave them in for the interview, but you likely might want to ask your patient to remove them if you're going to use the ultrasonic or a handpiece, because that can be very obnoxious if you have hearing aids. They should turn them down or remove them. Once treatment starts, probably just turning them down would be fine, because they can make a very loud squealing noise in the patient's ear. If they're accompanied by a caregiver, you want to speak directly to the patient, creating kind of this respectful environment. So you're not talking about the patient with the caregiver. You're addressing the patient, but the caregiver's there to be your backup kind of memory and remind the patient. And then we have to think about the legal considerations and informed consent. Are they still consenting on their own for treatment, or has this become somebody else's responsibility? So you have to take that into consideration as well. So in general, elderly people can be more complex. They have these chronic conditions. There's medications to consider, chronic conditions to consider, possibly more complications in the oral cavity with various diseases. So they can have more things going on, and more things that we have to consider. So we always have to just evaluate everybody for pre-medication. But with an elderly population, there's potentially a higher rate of individuals who would take a pre-med. So we have to have that awareness. Again, harking back to the functional versus chronological age, thinking about their functional age versus their chronological age. Their human needs are going to be different. They're not probably quite so concerned with aesthetics. They just don't want to be in pain, and they want to eat. However, everybody wants to feel comfortable, and they don't want to feel self-conscious. So it's important to assess your patient's needs and recognize that they're going to be unique for that person. And then perception of needed oral health care. Sometimes older individuals can take the stance where, I got all my dental work done years ago and I don't have any pain and I'm fine, not realizing that disease is brewing in their mouth. But when they have a limited income or fixed income, it can be something that they just sort of take out of their mind as something that's necessary, because it's expensive and they don't want to feel that it's going to be a necessary part of their finances unless they are in pain, and that always changes it for everybody. So educating them on the great importance of prevention, and how much more important that is as they age, because if they are in better health at a certain point in their age, then as they go along, and if they can keep implementing these good practices, hopefully that will prevent complex procedures from having to be done when they're really, in their 80s and 90s and what have you. So the reduction, things to also think about with implementation of a procedure is the reduction in healing capabilities. We want to try to have as little trauma as possible, because healing might be a little bit slower, especially depending on their overall health status. Oral retraction can be uncomfortable, and patients will tell you this. They'll say, "Oh, my lip always cracks." So sometimes lubricating their lips, especially if you just notice that they have a lot of dryness, they just seem drier. Just be really aware of that. Keep their mouth kind of moisturized. You can have them rinse with a lubricating mouthwash before you start, and you can use lubrication on the outside, like around their lips and the corners of their mouths, before you start the procedure to help with comfort. Specific oral hygiene instructions to ensure that they understand and that they also have the skill to perform those oral hygiene techniques. So modifying things like that where needed. The end of the appointment, we want to think about raising the chair slowly, because it's going to take, I always say, we want to give you a minute for your blood to equalize. You don't want to just pop them up out of the chair. Many times, even if they're not taking a high blood pressure medicine, they can feel dizzy. You kind of want to lay them back slow, sit them up slow, allow them to sit for a short period of time before you send them out the door. Assess their needs for assistance with walking. Postoperative oral hygiene instructions should be written and reviewed. Really ensure that they understand what their next steps are. They love that. They don't typically. I've never had patients feel like you were talking down to them, ensuring that they understood what their next steps were. They usually really appreciate it, especially if you do it in a very kind and loving manner, like you're watching out for their needs. Frequent perio maintenance appointments oftentimes is required. Even if there's not a lot of super active disease, just maintaining. If they're at high risk for things, it's good to put them on 3, 4, 5 month recall, just depending, and then evaluate carefully things like their psychological psychological sort of state, chronic conditions, pathologic findings. All of this stuff can change quickly. Their cognitive abilities you can track. If you have a patient that you see every 6 months for 10, 15 years, and you start seeing them when they're 60, and you're still seeing them when they're 75, you can really track cognitive changes. You know your patient, and you know when something's changing. So you really want, and if someone starts to develop some kind of dementia or Alzheimer's, you can really kind of help and advocate for that person with the family members. Say, I'm worried that they're forgetting to brush, they're forgetting to do the things that are, and I'm seeing these changes in their mouth. So you can be an advocate for your older patients in that manner. Evaluate functional abilities to complete their oral hygiene and nutritional changes. So we're just paying attention and noting changes as your patients age. With cognitive disorders, we see things like neglect leading to caries and perio, forgetting to do the oral hygiene. We see changes in the gingiva from medications. With somebody that has Alzheimer's, dementia, again, like I told you, you see this over and over. Finding out when their best time of day, typically early morning appointments when they're up and at 'em and they're feeling good. The caregivers usually know when those best times of their day are, but scheduling appointments when the office is not as busy, when it's not as hectic. New things can be confusing and frightening, and then if someone with cognitive disability or cognitive disorder gets frightened or confused, it can shut down very quickly. So you try and keep things the same and predictable and kind of light and happy. And approach things with caring and understanding of their situation, moving kind of slowly to what's comfortable for them. Doing things like that tell, show, do, limit their choices so we don't overwhelm them with things, just a really good thorough brushing and maybe some help with the interproximal brush or something. Speaking slowly, clearly, short sentences, and determining their ability to actually perform oral hygiene, or to do things like rinse and gargle. How they can handle fluid too, and their ability to do those various kinds of practices. Some things for the caregiver. So these things can help them if they, at home, propping them up on the bed with pillows. This thing says bean bags and airbags and different sized chairs, but just, things they could do oral hygiene while they're in their recliner. So just suggestions for them. Talking to the caregiver about the importance of removing appliances, physically supporting or aiding in the daily hygiene, because they really probably, if they have a caregiver, they probably can't do a very good job, so they really need that support. Visually inspecting and retracting their cheeks to really look in the oral, teaching the caregiver how to look in the oral cavity and see things and not be afraid of the oral cavity. Very many caregivers just want to pretend it's not even there. They find the oral cavity gross. They find it intimidating. They don't want to get bit. So, we really do have to educate the caregivers just as much, if not more, in that situation. Visually inspecting tissue for lesions and changes or broken teeth or infection, encouraging the patient during and after the care, and providing written instructions for the caregiver. Modifications, so this is just some review that we already talked about in other, but the handle size of the toothbrush, the shape of the toothbrush head, thinking about their dexterity and their vision, thinking about their ability to rinse or use something with water, lubricating the oral cavity because of xerostomia, different kinds of swabs and gauze. They have chlorhexidine swabs and things like that, powered flossers, water flossers, different kinds of cleaning tools that they might be able to use, and keeping things lubricated and moisturized. If there's xerostomia and the increased risk for caries, we have the fluoride gels, the 0.1% sodium fluoride, or the 0.4% stannous fluoride trays. There's all the xylitol products. There's the mechanical removal of the plaque with a powered toothbrush. A caregiver could use a powered toothbrush, or someone who's still capable, and that gives them a little bit more bang for their buck. I love the Oral-B. I use both the Oral-B and the Sonicare, but I actually prefer my Oral-B. Modifying handles when needed. You can see a couple of these examples of strapping the toothbrush to their hand. And we kind of talked about these things already here. So it's important to think about the patient's ability to get to the office, and their ability to even see a dentist at all. Thinking about transportation, the building itself, training caregivers, and then thinking about the overall patient's goals, like what has to be done and what does the dentist think should be done. Sometimes those don't always line up, and so we have to really think about what our patient's needs and desires are, and usually it's not always what the dentist ideally wants to do. So I just briefly touch on this, but there's a lot of on-site dental programs now. A lot more hygienists are getting into these long-term care facilities and nursing homes, and even dentists are starting to, there's some amazing models throughout the United States where dentists and hygienists work together, and some are just hygienists. But it was my first love, really, outside of clinical, was the idea of formulating your own business and all the different options that are out there. And there's just been progress, leaps and bounds in this. So it's really fun to think of developing your own strategy and getting your own patient base. And you can work with dentists or not. Of course, you're always going to refer to dentists, but they can, be a part of your business or not be a part of your business if you just have them as referrals. But anyways, advantages over the traditional dental office is obviously the patient doesn't have to go anywhere. You go to them. So that eliminates a lot of things. If they are incontinent, bedridden, catheterized, they just simply can't even have an option of going anywhere. It's less disruptive for their whole kind of routine if you go to the facility instead of trying to load them up into a transfer van and get them into your office. And then they're somewhere where they're comfortable, they feel at ease, and so it really does reduce stress. And then, of course, with providing care, it's nice to have kind of a permanent space in the place that you're going, but many times you'll end up, in somebody's room or something like that. There's a lot of portable dental equipment. Now they make just everything you could ever think of. There's a lot of mobile dental vehicles where they at least bring the dentist to the doorstep. They might not do the work in the patient's room or in the facility, but at least they have virtually brought the dentist's office to the doorstep of the patient. So really you just have to wheel them out the door and into your mobile dental van, which you guys obviously have wonderful experience with. So you understand that concept very well. Barriers to care, there's lots of them, of course. Insufficient number of dental health providers who are willing to work outside of the private practice and who are unwilling to work with this demographic because of the more difficulties and frustrations and complexities that can be there. Poor attitudes of dental professionals, the financial reimbursement, especially from the dentist's point of view, not necessarily so much from the dental hygiene point of view, but from the dental point of view, it's low return. Inadequate financial coverage. This is, they're expanding Medicare though, so this, they're expanding Medicaid and Medicare, so this is actually, could be changing in the future as the legislative changes occur. And then not covered under Medicare, which is federal, but many states have Medicaid, and that varies by states. But I know they've been doing a lot of, I'm not super up on it, but I know there's been a lot of changes with Medicaid and Medicare, and they're expanding dental coverage, which is good. So provide, the role as a dental hygienist is to provide clinical care, provide in-service education programs for staff and family. It's a wonderful exercise to go in. I mean, you could literally, it's not necessarily a place to make money. Oftentimes they don't pay you, but if you want to put to practice presentations, if you're interested in education and speaking, you can get a lot of training ground in hospitals, nursing homes, assisted living, giving in-service education programs for families and staff and caregivers, nurses and doctors even. It's really a great way to share the information and also get practice for yourself. Refer if they detect unusual signs or verbal complaints. The BOHSE evaluation is a brief oral health status examination. You can, it would be amazing if every nursing home or every system of nursing homes, say there's 5 nursing homes in the Portland Metro, they're all owned by the same company. Say all those nursing homes hired at least one hygienist to do every kind of onboarding of not only the staff and caregivers, but every new patient, every new resident that comes in, the hygienist does an evaluation. Not even necessarily cleaning, just evaluate because it's required. The nursing home has to have that done, but who does it? Well, inexperienced nurses and caregivers do it. They usually are done ineffectually, inefficiently, and a lot of times they miss stuff. Marking dentures for identification is huge. Dentures oftentimes get broken and lost in nursing homes. Giving fluoride application, developing an individual care plan, and modifying oral hygiene aids. I mean, hygienists would have a busy day if they were in charge of even just 3 or 5 places, that they had to make sure all their patients had all of this stuff going. It's a huge place, I think, of growth for hygienists who actually have a passion for this demographic. So now we'll talk a little bit about palliative care. So the definition, any form of care that focuses on decreasing disease symptom severity. So the symptom severity for an individual with life-limiting illness. So there's no talk here about curing. It's about let us help this patient transition comfortably. Let's make their life as comfortable as we can at this moment in time for them. So care does not involve delaying or reversing the disease progress. Palliative oral care management and prevention or oral problems caused by disease or treatment of disease. So we're just looking to it's not looking to prevent, or it's not looking to treat, should I say. We're looking to just manage what's there and prevent it from getting worse. That's the main goal there. The focus on patients' immediate quality of life. And then for goals, we want to provide relief from symptoms, especially pain. That's one of the biggest ones. We want to support the overall patient care and enhance their quality of life. We want to think about their whole holistic care is what we want to focus on. Offer support to patients to live as actively as possible until death, until they succumb to their disease. So it's really just being there, family support, patient support, and relieving discomfort. Affirm life and neither hasten nor postpone death. So you're just there to do what you can to help with this transition. You're not trying to, like I said, cure anything or kind of just help them to die, unless that's a very specific situation. You're just looking to help them in that transition. Regard dying as a normal process, and offer support to family during the patient's illness and in their own bereavement. So people who work in this area, they are really pretty special people, I think, overall. They have amazing skill sets, especially with their ability to just support people and offer that what's needed during that time. So it's pretty neat. Okay, let's see. So, standard palliative oral hygiene care. So if you happen to be in this situation where you're working in a hospital or a nursing home, or going into some home health and you working with somebody who's on palliative care, we want to determine the mouth determined to be overall healthy. If you go in there and there's not a lot going on with the mouth and you're just looking to maintain sort of the health, then then we're looking to brush the teeth, brush the tongue, lubricate, keep things moist. We want to think about the patient's ability to handle liquids. So things we really want to reduce, probably things that are very liquidy that can go down their throat. But you can use things like a suctioning toothbrush, or you can use things that don't foam up and bubble, that would be thicker, that they could actually handle. We also need to think about their denture care, utilizing a mouth rinse if possible, but it might not be possible. And then patient care for intubated patients. They're obviously can't handle any liquid, so there's the suctioning toothbrushes. And then we would have to use things like a mouth prop to actually get their mouth open so we can work in their mouth. Some oral complications that could be present. You think about somebody who is maybe end of life cancer patient or something. So, a lot of times we could see mucositis and ulcerations. These would be common with cancer, radiation therapies. Chemotherapy reduces the ability for the cells to sort of turn over and slough off. So sometimes there is I've seen a lot of images where people are like, what is happening in the mouth? And it's like cell buildup and like on the tongue and different areas, because there's might be dryness, and then the cells aren't kind of turning over and sloughing off. And so there's just this weird kind of thick, crusty look that needs to be sort of slowly cleaned off to help. You actually have to kind of help with that exfoliating. Keeping patients' mouth clean and moisturized is key to reducing and preventing mucositis. Possibly rinsing with chlorhexidine, although I don't know if that would always be appropriate. Topical corticosteroids can also be used in some of those situations with mucositis. Oral candidiasis, so there's going to be a higher prevalence of that. 70–80% of patients with palliative care may have an oral thrush imbalance in the oral flora and their immunity, so that's why you'll see it more often. And this can be treated topically with like a nystatin rinse or something, or some kind of a pill. Possibly they might have a systemic pill. Candida levels can be higher in the denture wearers. We know we got to be aware of that. Of course, always there's the dry mouth, and we know that by now. We're gonna just talk that to death this semester. So here's a couple things that can be utilized for somebody with mucositis. There's something called magic mouthwash, and this oftentimes has different things in it, and a lot of times an oncologist will prescribe it if they feel like this is going to be a problem. But it can be a rinse that has antihistamine, antifungal, and some kind of an anesthetic to help with pain, and then some kind of an antibiotic perhaps, and they swish with it like twice a day or something. There's also soothing, just baking soda saline rinse for more mild cases. There's topical lidocaines. Then there is other rinses where they use the diphenhydramine hydrochloride and the loperamide, and then Maalox. And they actually do equal parts because the Maalox is a coating, and then they get the other benefits from the other medications. And so they're just various rinses that are out there. So the process of care: interviewing the patient and the caregiver, finding out what's happening, performing a screenings, looking for yourself, diagnosing, and seeing how things change. Things can change rapidly. Planning the palliative care to maintain their oral comfort, their hydration, their pain management. Consulting with the other team members to kind of give your feedback and integrate the plan. And then of course you implement what you'll do, and then you're always evaluating what you've done to see if you need to change anything.